بسم الله الرحمن الرحيم. أنا يزيد البراك طالب سنة خامسة. Today إن شاء الله we will be talking about IBS. Today إن شاء الله in our lecture we will cover the definition, pathophysiology, clinical manifestations, diagnostic evaluation, criteria, management of IBS, and at the end إن شاء الله we will cover some questions to make sure that we understood this topic. If anyone has any questions during the lecture, please feel free to ask, okay? IBS refers to an idiopathic disorder associated with an intrinsic bowel motility dysfunction that affects 10 to 15% of all adults. So what is IBS? If we break down the word, irritable means pain or discomfort. Bowel means the small or large bowel intestine, and syndrome. So we could, from the name, we could understand this is a pain disorder, which is associated with an altered bowel movement. Also, it is an idiopathic disorder. So there is no known etiology for this syndrome, and it is based on theories. Also, it is associated with an intrinsic bowel motility dysfunction. As all we know, the small intestine and large intestine are controlled by peristalsis, and peristalsis is controlled by the enteric nervous system. IBS is believed it is a disorder of peristalsis. Okay, it affects 10 to 15% of all adults. So this is not a rare syndrome. Disorder of chronic abdominal pain relieved by a bowel movement. So whenever a patient presents and he says, I have chronic abdominal pain and it goes away after I have a bowel movement. So this makes us think about IBS. Also, it could be diarrhea, constipation, or both. So don't get تتلخبط إذا شفت إنه he has mixed diarrhea and constipation. It could happen. Symptoms are exacerbated by stress and irritants in the intestinal lumen. So if the patient states that he has some sort of stress in his life, either work, family, and he presents with these symptoms, we could think about IBS. Irritants in the intestinal lumen differ from person to person. So what could make a person irritant for one person, the other person usually could not complain of the same irritation. Symptoms should be present for at least 3 months to diagnose IBS. So, and I will elaborate more on this in the criteria section. Pathophysiology of IBS. As I said, there is no known etiology. It is based on theories. So it is a multifactorial syndrome. It is a multifactorial syndrome. It is associated, it could be associated with psychosocial factors, as I said. It has a genetic component also to it. Altered gut microbiota. As we all know, the small and large intestine have normal flora. Any alteration in these flora could affect and result in the development of IBS. Also, immune response that are altered in this person could affect the development of IBS. Clinical features. So if a patient presents with a change in his frequency or consistency of stool, diarrhea, constipation, or alternating, this is one of the clinical features. Cramping abdominal pain, and it is important to say, is it relieved by bowel movement or not? Location varies. So as we know, if a patient presents with abdominal pain, we take a thorough history asking about many things. But one thing is the location of pain. So if a patient with IBS present, he could present with a diffuse abdominal pain, pain in the right or lower quadrant. So don't get any. Also, the patient could present with bloating or feeling of abdominal distension. If the patient presents that he has abdominal distension, this also could lead to think about IBS. Always painful and never bloody or fatty. So if a patient presents with abdominal pain, if he presents with constipation or diarrhea that is not painful, we might not consider IBS. Also, the patient never presents with bloody stools or fatty stools. The bloody stool could be melena, it could be hematochezia, and also it could be occult. We could not see it. Fatty. The patient also will not present with fatty stools. Anyone know how could we assess if the patient has fatty stools? Yes, the patient will present with stools that float, and this could indicate that he has fatty stools. Also, the patient most likely will not complain of weight loss or constitutional symptoms like fever, fatigue, or loss of appetite, or any night sweats. Okay, there are some red flags that a patient could present with, and we should not ignore it. If a patient presents with anemia, either dizziness, loss of consciousness, fatigue, we should consider things other than IBS. Family history of colorectal cancer or IBD. Fever. If a patient presents with fever, we could consider an infectious origin. Bloody stools. As I said, it could be occult, hematochezia, or melena. Nocturnal symptoms. One important point I forgot to say is that patients with IBS usually do not wake in the middle of the night for an attack of abdominal pain and diarrhea. It could happen at night, but it will not wake the patient in the middle of the night, middle of his sleep. Large volume of diarrhea, greasy stools. Greasy stools, we could consider a malabsorption syndrome. Onset age more than 50. This could lead us to think about cancer. If you examined the patient and you found a palpable rectal mass, also this is a red flag. Severe diarrhea or constipation, recent antibiotic use. So if the patient was on a course of antibiotics and he presented with diarrhea, what could you suspect? أحد يعرف يجاوب؟ تسمعوني؟ شباب سامعيني؟
ايه واضح صح.
Okay. طيب recent antibiotic use. So the patient could develop C. diff. طيب rectal bleeding and weight loss. So a patient who presents with diarrhea or constipation, it has a very wide and broad differential diagnosis. طيب. So if a patient, for example, a colon cancer patient, he will have a different demographics, such as age. He will be older than 50. He will present with any sort of bleeding. طيب. IBD, the patient with IBD, either ulcerative colitis or Crohn's, the patient will usually present with, if he has Crohn's, he will present with anal disease such as fistula or ulcers. And both of them, they could present with extraintestinal manifestations such as arthritis, erythema marginatum, or skin infection or scleritis. This would exclude the diagnosis of IBS. The patient could be on drugs, either medical or abuse. Mesenteric ischemia. Usually a patient with mesenteric ischemia will be an elderly with atrial fibrillation. Celiac disease. Celiac disease is a common presentation or a diagnosis. So a patient usually present with fatty or greasy stools and a history of ingestion of gliadin or or gluten, and he will present with the diarrhea. Ischemic colitis in cases of severe hypotension, giardiasis, in a case of a person who lived in a non-sanitary area, pseudo-obstruction also, depression, somatization. As I said, IBS has an association with depression, any psychiatric disorder. Intermittent sigmoid volvulus, megacolon, or endometriosis. So it has a very broad differential diagnosis, and we should consider every differential diagnosis. The following must be frequently excluded in diagnosing IBS. Obstruction. Obstruction. The patient who presents with obstruction, he might have a hernia if he has a virgin abdomen, or he could present he might present with obstruction due to adhesions if he had a surgical procedure before, IBD, as we said, lactose or sorbitol intolerance. So these patients will present with diarrhea and fluctuants after eating or drinking any dairy products. Malignancy, as we said, in older patient or a family history. Based on these symptoms or presentations, we could do a colonoscopy to rule out or rule in, and blood in stool. So the diagnosis of IBS is a diagnosis of exclusion. You should exclude all other diagnoses, and then you can diagnose IBS. There are no laboratory markers that indicate IBS. So if they told you, is there a specific blood test, any radiological tests that you could perform to diagnose IBS, there is no. As I said, you must completely rule out all other potential causes of diarrhea, constipation. Stool studies will be normal. Colonoscopy if done, هم بالعادة ما يسوون colonoscopy، لكن إذا سووا it will be clear, normal, and no correlation with diarrhea in the case of lactose intolerance. So what are the initial tests that may help exclude other causes? ممكن تسوي CBC. If you did the CBC and you found maybe a low hemoglobin or low hematocrit, this could make you think about bleeding due to cancer maybe. Fecal occult blood test to exclude hidden bleeding due to cancer. Stool examination for ovoparasites in case of infection. ESR and CRP in the case of IBD, they could be elevated also. And a possible flexible sigmoidoscopy, but we don't do it unless there is an indication. Order these tests only if there is a suspicion of other causes for the symptoms. So IBS, in order to diagnose it, you have to fulfill a criteria, which is named after Rome 4. So the patient has recurrent abdominal pain for more than 1 day per week for at least 3 months. If the patient has this history, so we could consider IBS. Abdominal pain is associated with at least 2 of the following 3 symptoms. So we have to have 2 out of 3 pain related to defecation. As we said, if the patient has abdominal pain that is relieved after a bowel movement, we will consider IBS. Change in the frequency of stool, either diarrhea or constipation. Change in the form or the appearance of stool. In the lecture, I think, in the book, sorry, there is a picture or a diagram of types of feces. Any change in the normal, any change from the normal, we would consider IBS. So pain related to defecation, change in the frequency of stool, change in the form or the appearance of stool. If anyone has any questions, please ask. The patient has none of the following warning signs. زي ما قلنا قبل شوي. If the patient is more than 50, we would be afraid of cancer. if he has any recent change in bowel habit. As we said, it must happen, or he must have these symptoms for at least 3 months. No evidence of overt GI bleeding. Overt GI bleeding, he means here if he has active bleeding now. Nocturnal pain or passage of stool. As we said, IBS usually does not wake up the patient in the middle of the night for an abdominal pain. Unintentional weight loss, we could consider cancer or IBD in this case. Family history of colorectal cancer or IBD, palpable mass, evidence of iron deficiency anemia, positive test for fecal occult blood, any type of bleeding. So the treatment of IBS is symptomatic treatment. Every patient will have his own treatment based on his symptoms. One thing that is common for all patients is that they should be on a high fiber diet. For mild symptoms, diet and lifestyle changes such as avoiding dairy products, excessive caffeine. And every patient who is diagnosed with IBS will know his own irritants or anything that could cause an attack. So every patient will know his own irritation causes. So manage the symptoms below as indicated. So if a patient has an IBS that is primarily diarrhea, we will give him an antidiarrheal such as loperamide. If the patient has constipation, dominant IBS, we could give him anything that could relieve, such as any laxative, such as psyllium or anything other. Any abdominal pain, we will treat them with antispasmodics. And depending on the case, if the patient has any psychiatric disorders and the psychiatric doctor will see this patient, he could prescribe him any antidepressant, TCAs or SSRIs. طيب، في أحد عنده أي أسئلة؟ ولا نبدأ في الأسئلة؟ طيب، نبغى أحد يقرأ السؤال لو سمحتوا.